Bismillah ar-Rahman ar-Rahim. This is the third lecture of gastrointestinal fistulas. I will talk in this lecture about enterocutaneous fistula. Enterocutaneous fistula, proven strategies and updates. It is an apparent connection between the intra-abdominal gastrointestinal tract and the skin wound. There are several ways in which enterocutaneous fistula has been classified, including by output, etiology, and source. We are seeing here case of moderate output fistula. And we are seeing here fistula due to tuberculosis. And we are seeing here postnatal slough of the stump. Now I will talk about etiology of enterocutaneous fistula. Webster and Carey proposed 5 mechanisms of fistula formation. The first mechanism of fistula formation is congenital. This is rare. Failure of obliterate of vitello-intestinal duct. Postnatal slough of the stump. The second mechanism of fistula formation is trauma, major penetrating trauma. Damage control laparotomy techniques. The third mechanism of fistula formation is infection. Intra-abdominal abscess and invasive intestinal infections like hemoptysis, coccidioidomycosis, tuberculosis, etc. We are seeing here case of hemoptysis in the gastrointestinal tract, and we are seeing here gastric coccidioidomycosis presenting as outlet obstruction of the stomach. And we are seeing here fistula due to tuberculosis. Intestinal perforation in ileum from tuberculosis or enteric fever. Actinomycosis infection post-appendectomy. We are seeing here case of actinomycosis of appendix with a cecal abscess. The fourth mechanism of fistula formation is iatrogenic. Intra-abdominal abscess, 75 to 85% are iatrogenic after surgery for bowel obstruction, cancer in the abdomen, or inflammatory bowel disease. We are seeing here case of intra-abdominal abscess, and we are seeing here case of intestinal obstruction. But we are seeing here case of laparoscopic for colon cancer, and we are seeing here case of surgery for Crohn's disease. The fifth mechanism of fistula formation is inflammation, irradiation, or tumor. Crohn's disease may cause enterocutaneous fistula post, more common than spontaneous. Intracutaneous fistula after anastomosis, appendectomy, simple exploration in Crohn's disease, irradiation for pelvic malignancies, etc., may lead to a chronic non-healing enterocutaneous fistula. We are seeing here case of enterocutaneous fistula due to Crohn's disease, and we are seeing here case of radiation fistula. But we are seeing here case of enterocutaneous fistula after appendectomy, and we are seeing here intestinal anastomosis. Most often, a high output enterocutaneous fistula is characterized as one with more than 500 milliliter 24 hours. Low output enterocutaneous fistula less than 200 milliliter 24 hours, and a moderate output fistula between 200 and 500 milliliter 24 hours. While the great majority of enterocutaneous fistulas are iatrogenic, 75 to 85%, and to between 15 and 25% occur spontaneously. Now, common causes of iatrogenic enterocutaneous fistula are trauma, operations for malignancy associated with extensive adhesiolysis, or in the setting of inflammatory bowel disease. We are seeing here case of spontaneous inguinal enterocutaneous fistula, and we are seeing here case of enterocutaneous fistula due to Crohn's disease. With respect to post-operative small bowel fistula, about half are from an anastomotic leak, with the other half occurring from inadvertent injury to the small bowel during dissection. We are seeing here case of anastomotic leak after Whipple operation, but we are seeing here case of anastomotic leaks after colorectal operation. Spontaneous fistula occur from inflammatory bowel disease, most common, malignancy, appendicitis, diverticulitis, radiation, tuberculosis, actinomycosis, and ischemia. We are seeing here case of enterocutaneous fistula after appendectomy, but we are seeing here enterocutaneous fistula after bowel recurrent abdominal actinomycosis with multiple organs. Organ of origin is another classification used for enterocutaneous fistula and is useful as well in the consideration of management options. Type 1 abdominal, esophageal, gastroduodenal. Type 2 small bowel. Type 3 large bowel fistula. Type 4 enteroatmospheric fistula, or regardless of origin. We are seeing here case of gastroduodenal fistula, and we are seeing here case a midline enterocutaneous fistula, but we are seeing here multiple recurrent enterocutaneous fistula, and we are seeing here and here case of large bowel fistula, and we are seeing here case of enteroatmospheric fistula. Closure rates without operative intervention in the area of advanced wound care and parenteral nutrition or PN vary considerably in reports between 20 to 30% range. We are seeing here spontaneous closure based on physiology. With historical wound care measures, 90% of spontaneous closure occurred in the first month after sepsis resolution, with an additional 10% closing in the second month, and none-closing spontaneously after 2 months. Spontaneous closure based on fistula, character, and environment. Now I will talk about mortality rates of enterocutaneous fistula. In different series for patients with enterocutaneous fistula are also markedly variable in distribution between 5.5 to 33%. This is the mortality rate, with most deaths attributable to sepsis, malnutrition, and fluid electrolyte disturbances. We are seeing here mortality rates of many cases of enterocutaneous fistula. Now I will follow up mortality rates of enterocutaneous fistula. Factors that are predictive of high mortality rate are infectious and non-infectious complications, high output fistula, and age. In this slide we are seeing here 7% persisted enterocutaneous fistula after surgery, and 4% persisted enterocutaneous fistula after medical treatment, and mortality rate of enterocutaneous fistula is 38%, and spontaneous healing of enterocutaneous fistula is 29%. But healed after surgery for enterocutaneous fistula is 22%. Now I will talk about approach to enterocutaneous fistula. A common acronym used to describe enterocutaneous fistula care protocol is SNAP, which stands for Management of Skin and Sepsis Nutrition, Definition of Fistula Anatomy, and proposing a procedure to address the fistula. In this slide, we are seeing here management approach for enterocutaneous fistula. SNAP is stabilization, sepsis control, skin care. N, nutrition support. A, assessment of anatomy. P, plan of definitive treatment surgery. Many authors have suggested various stepwise systems and protocols for treating enterocutaneous fistula. In addition, it is important that patient is treated in a center with significant experience in treating enterocutaneous fistulas and that multidisciplinary approach is used. Technique advances in enterocutaneous fistula isolation after open abdomen. This latter measure results in 50% decrease in mortality rate. The different components of enterocutaneous fistula caries are listed as follows in the order of immediacy to the patient. In the end of this lecture, thank you for all.